Hello everyone, greetings from Colombia. My name is Luisa Casas. I'm working on developing of projects for the International Agency for the Prevention of Blindness, Iapb. Today, we are very pleased to participate in this meeting of NGOs about the world. And basically, we want to share briefly with you some of the points of our 2030 Insight strategy, ocular vision health, and others for the next 10 years. If we think about it, we did quite a very good job with the strategy of 2020 and the committees of the prevention of blindness around the world. But now is the time to take all these efforts forward and continue developing our strategy to decrease the amount of people blind around the world, that is 1.1 billion. The 2030 Insight strategy has three main components: elevate, integrate, and activate. Under elevate, we are hoping to develop over the next 10 years and strengthen all the willingness for the different governments and politicians to seek for more funds and financing all the projects of eye health. Basically trying to establish a link between the new objectives and the better use of other environments like school eye projects, also related to employees, and to start aligning all our programs under the sustainable goals of the Millennium Objectives. Let's welcome Jackie Adams, our expert from Fred Hollows Foundation Australia. She will share with us some of the successful experiences that they have that align with this pillar of Elevate.
Hi, I am Jackie Adams, and I'm coming to you from the Fred Hollows Foundation in Australia. I would like to acknowledge that I'm on the traditional lands of the Larrakia peoples, and I will pay my respects to them and their ancestors. I would like to extend that respect and acknowledgement to all Indigenous peoples on the call here today. I would also like to acknowledge that some of the images and voices of people used in this presentation may have passed away, and I extend my respect to them and their families. I am a proud Aboriginal and Torres Strait Islander. I'm a mother, a daughter, a sister, an auntie, a granddaughter. My family and my community connections is what drives me. I have ancestral links to the Withathi and Yatagana peoples of far north Queensland, the Gurindji peoples of central Western Northern Territory, and extended family ties across the Torres Straits and the Warlpiri in Yuendamu. Today's presentation will talk to you about the Fred Hollows Foundation, briefly our legacy, and briefly also on our work in Australia, particularly as it relates to Aboriginal and Torres Strait Islander peoples, our Indigenous peoples of Australia. The Fred Hollows Foundation is built on the legacy of the late ophthalmologist, Professor Fred Hollows. Fred worked within Australia from the 1960s. And not only is it a legacy of Fred, but it is a legacy that was led by Aboriginal and Torres Strait Islander peoples, leading the way in terms of how to respectfully engage and work with and ensure informed consent with Aboriginal and Torres Strait Islander peoples. The Fred Hollows Foundation today has a presence in more than 25 countries. And this year, we celebrate 30 years of the Fred Hollows Foundation. The vision of the foundation is that we wish to see a world where no one is needlessly blind or vision impaired. Our work in Australia unashamedly targets improving access to eye care for Aboriginal and Torres Strait Islander peoples. But it is also much broader than this. We support the right to sight, good health, and self-determination. Our work in Australia with Aboriginal and Torres Strait Islander peoples is built on long-term partnerships and core principles that guide the way we work and what we get involved in. The principles are on the screen for you, but ultimately The patient is at the center of everything that we do. We want to ensure that patients are informed, that they are making informed decisions, and that they provide their consent on the basis that they understand what they are providing that consent for. We hope that their processes through the system, from identification and screening to services, whether it be surgery or glasses, to referral pathways, to follow-up care, and to them being champions for their communities, ensuring that other Aboriginal and Torres Strait Islander peoples access eye care, is as seamless as possible. We do not compete for funding with Aboriginal and Torres Strait Islander organisations, and we also only go where we are asked to go. We must be invited in. This is the legacy of Fred and the Aboriginal and Torres Strait Islander peoples that worked with Fred back in the 1960s. This video gives you a quick explanation of an example of our work in terms of cataract intensive surgery activities.
It will be painful or no? Nothing, can't feel it, numb. Oh well, that's good. I like that part. I can see just a little bit, but I can't notice who he is. I have to call out for my grandkids. Tell them, come back, I can't see you. That's why I'll go and stay inside.
It's really about building equity, between all Australians. It's just mind-blowing how many people are legally blind when they simply need this operation.
Blindness is avoidable in 94% of the cases, but if you don't have access to the services in a timely manner, then your eyes will just get worse and worse and worse. We put the patient at the centre of everything that we do, and if we're working with and for Aboriginal and Torres Strait Islander people, then culture must play a part.
Oh, well, that's be good for me if I can have a good eye again. And I can see my grandson walking across the road, even in the dark.
We put everyone on the bus, get everyone to Darwin. We'll get 20 people all settled in, make sure they're comfortable and settled at the hospital. Then one by one we'll just roll into the theatre.
The eye health program is a fantastic program. There are lots of patients, they are getting benefit. When I finished the surgery, she said, "That's it, finished." She was very happy. Tomorrow when they can see, when we see their faces with a smile, that's more than everything.
The efficacy and benefits of cataract surgery are phenomenal. They're going to sing the praise of this operation to all their friends.
When I come back, I tell all my children, my family, I'll tell them, I can see it. He will be
Aboriginal and Torres Strait Islander people in Australia have the highest burden of disease and are dying a lot younger than other Australians. Aboriginal and Torres Strait Islander adults are 3 times more likely to go blind than other Australians. As a non-Indigenous organisation, the Fred Hollows Foundation has a role to play as a true ally and holding others publicly accountable to ensure that Aboriginal and Torres Strait Islander peoples continue to have the right to sight, good health, and self-determination. Thank you for your time today. It was a very brief presentation, and I'm always here if you want any more information or if I can assist further in any way. Thank you, and please take care.
Under integration, we are hoping that this 2030 insight strategy is focusing more on national health plans, increasing the cataract effective surgery coverage and refractive error solutions substantially, aligned with the WHO global targets. Also increase the services of vision rehabilitation widely, making it more available to anyone with visual impairment or blindness. Increasing the relationship with the private sector by facilitating partnerships to deliver affordable eye care services, as well as taking into account the new recently launched WHO competencies framework.
Let's welcome our next speaker, Venkatesh from Aravind Hospital.
To speak to us today about integration.
Thank you for the opportunity to talk in your meeting. So I'm going to talk about how Aravind Eye Care System is reaching the unreached using technology. This is the story of integrating eye health with broader health system. There is a significant problem of blindness, almost 36 million in this world. And if you see, the number of vision impaired is almost 7-8 times more than the blind people, almost 217 million, of which, if you see, 1/3 or 1/4 live in a country like India. So we have a huge problem of both blindness and also visual impairment, which we need to take care. And we all know that 80% of this blindness is kind of avoidable or unnecessary. When you see this distorted map of blindness, the problem of blindness is huge in developing countries like how you see in India, China, rest of Asia, Africa, but definitely in the Western world, they don't have much of a problem. At the same time, when you see the practicing ophthalmologist, you can see Africa is almost nowhere. It has got shrunk. In India, it's still not very adequate. Whereas in the Western world and Europe, you can see they have good number of practicing ophthalmologists to take care of this problem. With this background, Aravind started in the year 1976 with 11 beds. And now we have 7 tertiary care centers, 7 secondary care centers, 6 outpatient clinics, and also 102 primary eye care centers or vision centers. Through these network of hospitals, we see close to 16,000 outpatients a day. We do 1,700 surgeries. We do a lot of outreach activities in the form of comprehensive outreach, diabetic retinopathy, ROP screening, school screening, and by which we also get a lot of patients to the base hospital for surgery. And being a high volume center, we are involved in teaching 350 plus residents and fellows, and also a lot of technician and administrators come for training program at Aravind. So to simplify the challenge of universal health, there should be a balance between the demand and supply. Closing the loop is very important. Sometimes we may diagnose but not treat. Sometimes we may treat, we may not follow. So what are the strategies we are doing here? No, are we getting everyone in when we are seeing the patients? In diagnosis, are we advising everyone who will benefit? And is everyone advised getting the intervention? For example, a laser treatment or a surgery for cataract or maybe a complex procedure. It is very important to keep on looking some of this and plugging the leakages so that our time and resources are optimally used. There are some high-level challenges, for universal eye health. On the demand side, access. Eye care is kind of skewed towards large urban centers. You have eye hospitals, whereas the semi-urban rural places don't have many facilities. Again, affordability. It costs a lot to access care and also to pay for it. So that is where Aravind not only has base hospitals, but also it does a lot of outreach like the video which you are seeing now. Now, this is an eye camp which is happening. We do almost 3,000 eye camps every year like this, through which we see a significant number of patients and we advise treatment. If they need a cataract surgery, they are brought to the base hospital. As you see here, we have a set of ophthalmic personnel who are like technicians who help the doctors. They do vision testing, and after the doctor examines, they do refraction for these patients. So these are all makeshift cubicles. The intraocular pressure is checked. Everything is entered into an camp outreach-based electronic medical record. We also fundus the image, which is very important because seeing a fundus in the campsite may be very difficult. So we use these portable cameras to image the fundus, upload into the EMR, so the doctors can see even the posterior segment comfortably and then advise treatment. If they need surgery, they will be bused to the base hospital. But if they need any prescription, they would be given locally. By doing this outreach, what we found that only 7% of people who really need care were accessing the care. Still, there were a lot of unaddressed problems. So that is when we realized that we need to move from outreach to more concrete facilities. So we need to provide permanent eye care services in rural area. We have to kind of inculcate a proactive health-seeking behavior, and this would increase the uptake of eye care. And that is how we started the primary eye care centers or vision centers. So each of the tertiary hospital now have 10 to 30 vision centers under their belt, through which telemedicine happens. Initially, we had to look at technology. 20 years back, when broadband connectivity was not available, we collaborated with the University of Berkeley to set up a kind of low-cost Wi-Fi connectivity through using unidirectional antennas. But now we have excellent broadband connectivity, and we have 102 vision centers across our system. These centers now almost cover a 20 million population now in the state of Tamil Nadu and Pondicherry. More than 500,000 patient visits they see every year. And if you see in that particular area where it is located, 40% of the patients who need care come in the first year and almost 75% by the end of second year. And more importantly, 85 to 90% of the problems are resolved locally so that they don't have to travel to another center. So somewhere the budget for setting up the 600 square feet facility with basic ophthalmic equipments like slit lamp, trial set for refraction, an optical shop, a telemedicine unit, computer connectivity, everything roughly around $15,000. And to operate, roughly it cost around $750. And we have a very nominal consultation fees of 20 rupees for checkup, and then they pay for their medicine and glasses. And usually the running cost breaks even in 2 to 3 years. It's kind of financially sustainable after a few years. Initially, we used even digital cameras to fundus image, but now we have the fundus on phone, the low-cost technology cameras, and the photos are uploaded into the EMR like how you saw in the outreach. And then the EMR is seen by the doctor on the other side. The fundus image is seen, and then they give a prescription in the form of glass prescription or medicine, and patients who need treatment are referred. So we also use a lot of the low-cost technology here. In this video, you can see one of the patients visiting a vision center, which is in a rural area. We have two staff. One is a kind of a clerical staff who does registration and takes care of the optical shop. And the other person is an optometrist who is trained to do basic eye examination, including refraction, slit lamp examination, measuring their intraocular pressure like this, which is very important for glaucoma screening for anybody above the age of 35, 40. Then they dilate the pupil wherever it is necessary. And they also see the fundus using a 90 diopter lens. But what they see may not translate sometimes into perfect diagnosis. So they also image, and this is the fundus on phone, which you see here. It's a low-cost technology to image the fundus, and then the fundus imaging is kind of uploaded into the EMR. This is now done through cable, but now it can be seamlessly done wireless to the electronic medical record like this. And this image are shared through the EMR to the teleconsult doctor. The teleconsult doctor is usually a senior resident from the hospital. So they see those images and they take care of like 2-3 vision centers. They see like 110 patients daily and do teleconsult to the patient. And patients who need treatment are referred to the base hospital. And 85% of the problem is solved there. This is the EMR page which you see, and this is the glass prescription which is signed by the doctor and printed at the vision center. And this system, we are very closely working with the government of India, and we have set up some vision centers in states of Tripura, Jharkhand, Chhattisgarh, Uttar Pradesh, and several other states, and even in our neighboring country like Bangladesh, where we have set up vision centers so that they can integrate this into a primary health center also. Again, on the supply side, we have problems with efficiency, managing exceptions, and also kind of sustaining the quality. So which is again very, very important. We need to kind of take care of the supply side. So we are also looking at options wherever possible. For example, the retinopathy of prematurity is a major problem for blindness in children. Again, these children to reach a hospital is very difficult because they are preterm children who are sick. Their mother is also not in a condition of moving. So what we did was we integrated systems wherein we will go to the neonatal care center with technology, with facilities like this. So this is what you are seeing from Aravind Eye Hospital, Coimbatore, where they have a red cam. No, it's a facility to screen these neonatal babies, and it's a technology which can beautifully image, and then these images are transferred through electronic medical record to the base hospital grading center, where the doctor sees and then gives a report back immediately. So the mother is counseled about treatment or follow-up. And this is very critical because this has to be done in a very critical period, which is 2 to 3 weeks after birth. And these babies are very sick. They are preterm, and the mothers are also not in a situation to move them around. So technology, and then reaching the technology to the right time, to the correct facility. For example, here being a neonatal care center is very important in bringing a kind of universal eye health. So from a few districts around Coimbatore, now this system is across the state of Tamil Nadu. We have replicated in other tertiary care centers in Pondicherry, Chennai, and we have covered almost the state of Tamil Nadu and Pondicherry with this daily ROP screening. The other important cause for blindness is diabetic retinopathy, and diabetic retinopathy patients who come to the base hospital already have significant visual problems. So if we need to tackle this, we have to tackle at primary level and district level. In our vision centers, we image all diabetic patients and screen for diabetic retinopathy. But now we have tied up with the primary health centers at district levels, where they come for their treatment, where they come to collect their tablets. So that is where it is very important to integrate. So this is another important project wherein we have tied up with the district level hospitals in the Tirunelveli district, where you can see the patients who are coming for the non-communicable disease clinic, for diabetic retinopathy screening. In addition to their regular test, they also check the vision, and they have a fundus camera, another portable fundus camera through which images are taken, and then the reporting is done and given back to them. If they are needed any referral and treatment, they are referred to an eye hospital for further management. And now in this context, we are actively using artificial intelligence so that the report can be generated immediately within a few seconds, whether the patient can be followed up or referred. And this report really helps them to immediately take care. So this is what you are seeing. We are working very closely with several AI platforms, including the Google team, and now the Google AI software is being used. So once you feed the image, immediately you get a report whether it is saying it's mild or moderate or severe, whether the patient needs referral. So this really helps the technician on the other side to give report, and also significantly reduces the burden for the doctors to give the reporting in time. So by this way, we have integrated a lot of low-cost technology, and also we have integrated into health system in the form of neonatal clinics, diabetic clinics, and we have collaborated with the government and other health system to take eye care to prevent needless blindness. Thank you.
Last but not least is activate. This part of the strategy is related to our consumers, our patients, all the awareness campaigns that we can facilitate to come to them and to hear about the news, their needs, and integrate their needs into the rest of the activities that we are planning. For example, the campaign of Bullseye Day that Iapb has been leading throughout the years and has been a success in the 2020 Prevention of Blindness committees. To hear more about a successful experience on Activate, let's hear our speaker from Visualiza Guatemala, Dr. Lucia Silva. She has been working for a while now under the implementation of technologies, and she will share with us the experience regarding the work that they do to come closer to the communities. Welcome, Lucia.
Hello, my name is Dr. Lucia Silva. I'm an ophthalmologist and medical director at Visualiza Eye Clinic in Guatemala City. Visualiza is an eye clinic that has more than 20 years working with the communities in Guatemala. We have a private clinic that takes care of patients that can't afford to pay for their consult, but we also have a social clinic which is more focused in attending all these kind of patients that cannot afford an expensive consult and that have low income resources. So we have this social service to give the opportunity to every people to have an adequate ocular health. One of the ways that we reach to the communities is not only making it accessible by a social clinic in the city, but we also have detected that all the communities have needs in terms of visual health. So besides offering the people the opportunity to come to our clinic in the city, we have detected that some people are not even capable of coming to the clinic by themselves. So one of the most important parts of Visualiza in a way to reach the communities is making outreach camps. So we have a very strong team of outreach camps that go outside to search patients in need of visual health. These are called our Jornadas team. So they organize activities every week and every month to reach different communities that cannot come to us to search for ocular health. So every year we attend more than 3,000 people just by outreach camps, and we try to get to all those communities that have not an easy access to a visual center attention or to an eye clinic. At the beginning of the clinic, the outreach camps were going outside the city in the most vulnerable places, but near the Guatemala City. After the clinic has been growing up so fast, we first started with another hospital outside Guatemala City in Petén in the north of the country. So this was our first hospital outside the city, which already also organized outreach team that was going out to the communities in Petén to search people in need of visual attention. Once they detected they have refractive errors, they could prescribe glasses in the outreach camps. But then if they detected somebody who needed, for example, surgery or a specialized attention from the ophthalmologist, they took the patients to the clinic. We provided transportation and they took the patients to the clinic in search of the attention and sometimes even for surgery. After we started having the hospital in Petén, we started to detect that there was a need in all the country to get this visual attention. So Visualiza started to open some clinics called vision centers, which are small clinics that are attended by optometrists who give attention to people in different communities. The goal of the vision center is to be localized in strategic communities that are in need of visual attention and that also have very near communities in need of attention. So right now we have 6 vision centers in the country which are focused on giving attention in these communities, but also they have promoters of visual health that go out to the communities near the vision center to detect patients that need attention, and they take patients to the vision center if they need more specialized attention or if they need refraction to get their eyeglasses. And in case they need to be evaluated by an ophthalmologist, we have a teleconsultation system in which we take images of the anterior segment and the posterior segment of the eye, and these are transmitted to an ophthalmologist in the city, which evaluates the images and detects eye problems. And if in case the patient is needed to get attention in a hospital, we coordinate from the vision center transportation to take the patient to the nearest big hospital of the clinic. Right now we have the central hospital in the city, in Guatemala City, but we also have the hospital in Petén in the north of the country, and we have in the west side of the country the hospital in Xela. So this way we have our main hospitals, and we also have these small vision centers that take out outreach camps to detect patients in the communities around, and if there have local things that can be solved in the vision centers, they solve the things in the vision centers. And otherwise, if the patient needs surgery or more specialized attention, they bring these patients from the vision center to the main hospitals to get the attention. So in this way, we try to get to all the people in need, and we try to decentralize our attention. And in case something more specialized is needed, patients have the opportunity to get to us through the vision center's transportation that we provide. So considering that Visualiza has 20 years almost of existence, all the work that has been doing in all these years has been tough. It has not been easy to go to the communities, to start a hospital outside the city, and also establishing the vision centers has been a very hard work. But we realize that this is needed because there are so many people in the country in need of a proper visual attention. So our goal is to start opening more vision centers in the country, and hopefully in some years we can be able to have a vision center in every department of the country, and we are going to be able to provide a quality visual health attention to every people in need, even people from low income that they cannot afford to pay for another private consult, and ideally to continue to fight the avoidable blindness.